Welcome. Glad you could come this afternoon. My name is Lisa Everson, and we are here today to talk about MRSA prevention program that we'd like to introduce here at our facility. It's methicillin-resistant Staphylococcus aureus, and that stands for MRSA. Our current policy here at our facility is every patient that is diagnosed with MRSA, even if they've had it 5 years ago, they would be considered as having positive MRSA. So whether they have an open wound or just a history of it, they're still going to be treated like they have full-blown MRSA. The consequences of doing this policy the way it is patients are needed to have private rooms. We don't have enough private rooms here, so it takes a lot of juggling to try to get patients facilitated into a room. Also, the equipment that they use for patients has to be cleaned a special way. The room has to actually be cleaned after the patient leaves. There's a lot into it when a patient is diagnosed with MRSA and has a room. Wearing the personal protective gown, glove, mask, all of that ties in also. And then the patients that we have on our surgical surgery units have to be scheduled last of the day because they don't like to do patients after a MRSA patient has been done, so that there's no chance of transmission of MRSA. And also the surgeons, if a patient has a history of MRSA, then they will use vancomycin rather than choosing a less costly antibiotic for the surgery. Literature that supports this, many hospitals throughout the United States have done these tests and have proven that we should not be we should not be treating all patients with MRSA positive without screening them first. One of the articles that I read was MRSA screening, and it told about, it reiterates the importance of the screening and why we're doing the screening. It explains the rationale for the nasal swab. The nasal swab used to be a 3-day process. You had to get swabbed and then come back another day, get swabbed again. And now they have a new swab out that's just a one-time swab, and the results will return in 1 to 2 days. And this is explained in this article. Also, they tell you about the importance of the patient being asymptomatic. So if a patient comes in and they have a wound, and you're testing them for MRSA, or they just have a wound and they're coming in for something else, these patients should be treated as if they have MRSA for the guidelines. Another article that I read was surgical site infections associated with methicillin-resistant Staphylococcus aureus. Do postoperative factors play a role? This article explained about MRSA increased the cost of the patients for that private room, for those items that you used in the private room, for the vancomycin. It also showed that MRSA causes about 50% of hospital-acquired infections. So if you have 5 patients on a unit that is MRSA positive versus 15 that had a history of MRSA, then everybody's going to take those 5 patients a lot more serious. And that's also ties in with the workload of the nursing staff. In this article, it proved that nurses are one of the reasons that we are 50%, because we are not following protocol like it should be with the MRSA patients. And this article says that it's because we're treating everybody as if they have MRSA. Another good article was effectiveness of hospital-wide selective screening program for MRSA carriers at hospital admissions to prevent hospital-acquired MRSA infections. Now this article screened everybody that came into their facility. So whether you had a history of MRSA or an active MRSA, and they would put their patients into isolation according to those results. They would, if they had a history of MRSA, they would put them in isolation, and then the results come back, they would reverse it. And they showed that they had a very large decreased number of isolation in the cost also went down. And that the nurses took these MRSA patients much more serious when they realized, yes, the patient that I have really does have MRSA. The purpose of the MRSA screening to start at our facility was, the purpose of it is to decrease the amount of patients that we have in isolation, to decrease the patient's stigmatism of having this MRSA, history of MRSA, and they no longer have. We would start this program at the surgical services office. When the patient comes in and they have a history of MRSA, then the surgeon would write an order if they're going to have surgery to go with them to pre-admissions, and they would be tested there. And if they had a wound presently, they would not test these patients. The patient would then go to pre-admissions. Pre-admissions would do their history, and they would place this order that the surgeon has written in the computer to be swabbed at this time. The pre-admission would also, again, explain to the patient why we do it and what the purpose of it. And 99% of the time, patients want to be cleared of it. You do find a patient here or there that likes to have that private room automatically, but very rarely do you find that. Once the pre-admission has done the test, then they will go to, the patient will go home, but the information that's the test and stuff that's been collected, day surgery staff puts a chart together, and they will notify the operating room that this patient does not need to be in isolation any longer. They will not have to be last on the surgical schedule, and the patient will this will be explained to the patient when they come in the day of surgery, and they will not have to be in a private room and isolation precautions and all of that. And the surgeon will explain this to them, and they'll also change their plan of care, possibly rather than having vancomycin ordered, they'll do another antibiotic. Once the patient is notified and the plan of care is changed and everything, then the patient will, if they're admitted, then they'll no longer have this. We'll also notify infection control of our hospital so they can take it off, them off the list of isolation. We hope to learn from this study that not everybody needs to be treated as if they have MRSA. That we need to, if a patient has a history of MRSA, we need to nasal swab them and clear them. We need to do this for the patient, for better care for the patient, less expense for the hospital, and a cost beneficiary, and they can, this will, we need to be an active surveillance for these patients so that we can get this MRSA under control and give better care to our patients, and we need to support this plan so that we can change our policy. Thank you. Are there any questions?
I actually have one.
Okay.
Do you have dedicated equipment in your rooms for MRSA patients, or do you have to take equipment in and out?
We actually have to take them in and out. So some of the units have disposable items. At our unit that we use, we take the equipment in and out, and we have to clean it after each patient. So it's, you know, a lot of time and expense for them. Any other questions? All right. Thank you very much.
Thank you.